Hi, my name is Lauren Taylor. I am one of the nurse practitioners at West Cancer Clinic. I am in the Department of Palliative Medicine. And so we do mostly all symptom management for patients. Now, not all patients come to us. The majority of patients do, especially if they are metastatic. And so we just help with symptom management in regards to cancer and cancer treatments and what may be going on. So today I first wanted to, talk about two big symptoms that we manage: pain and anxiety. And those are ones that we prescribe both opioids and benzos for. And so those are huge topics to discuss. And so this is going to discuss reducing the risk of opioid and benzos with co-prescriptions and how to better manage pain and anxiety, which again are probably two of our biggest symptoms that we do manage for both cancer patients, but also survivors. And so, pain and anxiety in cancer patients. So, the increased prevalence of pain and anxiety in patients with cancer, plus cancer survivorship, can be attributed to a lot of different complex issues with physical, psychological, social factors. And this puts patients at higher risk of using analgesics and anxiolytics. And so this is just saying that both pain and anxiety are components of these patients' symptoms. And a lot of times also physical issues come in play with this, as well as psychological, but also social factors play a lot in pain and anxiety with these patients. And again, like I just discussed, that it's not just in patients with active cancer and getting treatment, but it's also patients in survivorship that are dealing with still both of these issues from either the cancer itself or treatment of the cancer that we did. So the prevalence of pain in cancer patients, one of the big things is that survivors in treatments report similar levels of pain as those who have completed treatment. So this is just saying that even though these patients get a clean status as far as their PET scan or their CT scan, and they get, labeled no evidence of disease seen, they still have lingering side effects from a lot of times the treatment or surgeries or whatever that happened to get rid of the cancer. And so a lot of times your survivorship patients are still having to deal a lot with pain and anxiety for the majority of the things, such as like nausea, vomiting, diarrhea, like those type of things get better with treatment not being used, because those are side effects from the treatment or radiation being done. But from a pain and anxiety standpoint, survivors still do deal a lot with these two issues. The rates of chronic pain in survivors is high. And so 31% versus 16% just in the general population. So that just shows that we are treating a higher number of patients that are having chronic pain regarding their treatment that they had, or just their cancer in general. And with this, patients normally, especially in survivorship, have employment, financial difficulties. And this is because a lot of times, especially in the employment aspect, they can't hold down a job for a very long time because they have pain that keeps them from either going to work or being able to do the duties that work needs them to do. And so a lot of times they find themselves unemployed, and then that just causes them to have financial difficulties, and then just kind of everything else in life kind of escalates at that point with these patients. And so that's a lot to do with survivorship as well that we have to deal with. And so especially if their pain is uncontrolled, then these different circumstances like employment and financial difficulties, they do continually escalate at that point. And so this is just from a pain and an opioid prescription. And again, this is in survivors. And so this was a national survey that looked at about 5,000 patients. And the pain prevalence in cancer patients is something that is, again, on the higher side. So 60% of of patients with pain are getting active treatment. And so that leaves 35% are actually survivors. And so, most are in active treatment, but you still have a huge number of patients that need help with their pain post getting finished with treatment and having that quote unquote no evidence of disease status. And within that 35%, it's also a really high number of high impact pain, and that's about 16%. So about half is telling us that they have high impact pain, which that just means that it affects their daily living. So they cannot continue to go on about their everyday life. They can't hold down jobs. They can't, get in the floor and play with their grandkids or do, everything that they should be able to do from a daily living standpoint because of the amount of pain that they're in. And that is a very high percentage of patients. But again, it just truly shows that patients, the day that they get, deemed cancer free, all of their symptoms don't just resolve at that point in time. So this next point is for opioid use versus misuse, and that's in the last 12 months. So your general population, that's just generalized across the board, about 31% of the general population uses opioids in the last 12 months. Now, this can be just from an opioid from after surgery. Like this is all opioids, no matter how long that they were used. But 31% uses opioids. And about 4.3% of that general population misused the opioids, again, within the last 12 months. Now, the next is recent cancer. So that's less than 12 months or actively getting treatment. And that is 54% continually uses opioids, but only 3.5% misuse opioids. And then remote cancer is going to be your survivorship patients, which that's deemed anybody greater than 12 months. So that would be 39% are still having to use opioids, but the misuse is down to 3.0%. So what this shows you is that, yes, the patients with cancer and even survivorship are having to use more opioid, like more of the population is using opioids, but the misuse is a lot less in percentage wise than just your general population. But again, just because they have a cancer diagnosis or a remote cancer diagnosis does not keep all patients from misusing opioids. And so that's something that also comes into play when you are prescribing these type of medications. And then one just kind of, thing to take in is that opioid use back to baseline at the year 6 mark of survivorship. So a lot of times what we have seen is that it can take up to 6 years for patients, once they get that NAD status and they're cancer free, to get them back to what their baseline was. Some patients were already on opioids prior, some weren't. But if they were on it and they come to us and we take over while they're getting treatment, then we have noticed that it takes about 6 years to get them back to what they were on when they first got diagnosed with cancer. And then balancing comfort and caution in palliative care. So, palliative care, we walk this fine line, is kind of what we tell patients of what can we do to make you comfortable, but also we have to do it with caution because you are, fighting for your life to beat this cancer and to be able to live as long as possible with a quality of life. So we don't want to give you anything or do anything to hasten that. And so it's really a fine line of balancing that comfort and caution. And a lot of times I tell patients is that to have cancer and for pain management, sometimes it's not realistic to say, we're going to give you this pain medicine and then all your pain's going to go completely away and you're going to be at 0 out of 10 pain. Sometimes that's not realistic. I would say a lot of times it's not realistic, especially in your metastatic patients. So what the goal would be is what can we give you to make your pain tolerable so that you can continue living life? You can continue going to the grocery store. You can continue playing with your grandkids or whatever needs to be done. Some patients, still working. What can you continue to do at work while your pain is tolerable, but still there and not a 0 out of 10 pain management? And so balancing that, you really have to take into effect that the doses of opioids for cancer patients are normally higher than those that are just of the general population. This is just meaning that, yes, our patients with cancer do use more pain medicine, but the dosage of the pain medicines are usually higher than what just the general population is using. And because of this, it increases the risk of death from overdose if you're misusing the medication. And so we have to kind of take that into consideration too, and really talk with our patients about, like, these are at high doses of what we're giving you to make your pain tolerable. And so any type of misuse from them can be really dangerous. And so that's a conversation we have with every patient. And for the reason of, again, like these medicines can be dangerous if used inappropriately. And so, the pandemic increased overdose risk in all patients. This is general population, not just cancer. About 32% increase in US overdose deaths during the pandemic. And that was from February 2020 to 2021. And so there also is, within palliative care, we have to kind of watch and recognize those lines of what's malignancy pain and what's chronic pain. Because like if you have, chronic back pain that you had prior to your cancer diagnosis, those are two different things. And those are, being able to manage those may look different from a palliative standpoint. And then, so this, talking about opioids and benzos, this was during, the 2010 opioid crisis that went through. So this is just saying that the concurrent opioid and benzo prescription rate was about, prior to, in 2008, was about 21%. 10 years later after, it only decreased down to 20%. And then the co-prescription of opioids, and that's just general population. Now this is about the opioids and benzos in survivors as high as 30%. Now this is related to cancer patients. So your survivors, their co-prescriptions are still high and is as high as 30%. Co-prescriptions in chronic pain though, and that's not cancer related pain, that's just chronic pain management, is as high as 47%. And so that just shows that, yes, from a cancer standpoint, we're doing better at co-prescription than just the general population, but it is still pretty high up there at the 30%. This graph is just showing that the benzo use has been in an upward trajectory for some time. And so the gray bar graph is showing just all benzos. The orange is your short-acting benzos. Mostly this is going to be your Xanaxes. And then your blue line is your long-acting benzos. And so you can see that from, even from 2003 to 2015, that it has been on a slow incline and almost doubled from 3.8% to 7.4%. And that, that's about a 95% increase over the last 12 years. Now this box saying about the 30.6 million. And so what this is saying is that of all people in the United States, 30.6 million people within the last year has used a benzodiazepine. Now that takes everything into consideration, whether it's just one for an MRI scan that they had or anything like that. This is just all benzos in kind of grouped into one for all population, but that's still a pretty high number of patients that just in the last 12 months has used a benzodiazepine. So the co-prescription of opioids and benzos, are we asking for trouble doing that? In 2021, nearly 14% of US opioid overdose deaths included benzodiazepines, which that's a pretty high number. And the risk of overdose for opioid users, along with benzos, increases your risk by tenfold. And that's huge. And that's something that, when you are thinking about possibly prescribing both, that you need to talk to your patients about, that doing both together, how dangerous it can be, especially if they're misused. So some examples of substandard opioid and benzo prescribing is utilizing opioids or benzos as your first line therapy without any consideration of alternatives. At palliative care here at West, our first go-to is not going to be a benzo if you're coming in for anxiety. We're going to try other things before we get to that. And so that would be the best thing to do. Prescribing opioids or sedatives, that's going to be your Ambiens and benzos without informed consents of risk or consideration of weaning protocols. And so that's just saying that you need to be talking and documenting that you went over all the risk with your patients when you're prescribing both together. You should always be checking the CSMD to make sure that patients aren't getting prescriptions from other providers that you were unaware of. Multiple team prescribing, when you are working in a large clinic and you do have multiple teams, an oncology team, a radiation team, a palliative team, one team needs to be managing these controlled substances just because of the risk of what could happen if multiple people were prescribing, especially if they were doing opioids and benzos together. And then you need to use a monitoring effect. We use the PEG-3 for pain and the GAD-7 for anxiety. Those can just be looked up on Google and used. And then also being able to order your random UDSs and being able to interpret them with whoever runs your labs. So how does West maintain a low prescription rate for co-prescriptions? We don't use benzos very often. We try all the others things prior to get into the point of using a benzodiazepine. That's kind of our last go-to if they're using opioids as well. And so listed below are all the other types of management that we can use for anxiety before we go to a benzodiazepine. And so just some little pearls from the team here at West. This is our palliative care team, Dr. Clay Jackson, myself, and then Summer Brannon. And so just some takeaways is that pain is both common in active treatment and survivorship. So again, patients after getting an entity status are still going to have pain and anxiety. Cancer patients are more likely to use, but they're less likely to abuse than the general population. But if they do misuse, it's normally more risky than the general population as well. Co-prescriptions of opioids and benzos is fraught with risk, and it should be minimized to the lowest amount of patients possible. And then if you do co-prescribe, then you always need to send a naloxone prescription and discuss the risk with the patient and the family so that if anything does happen, that you have discussed this with the patient, they know how to use Narcan if needed. And so those are just really your pearls that if it comes down to it and you need to do these two things together, then this is a safe way to do that. Thank you for coming and listening to this. And if you have any questions, I will be available to take any questions at this time.